Good morning, everyone. We'd like to welcome you all to the Buncke Clinic Virtual Visiting Professor Series. We are delighted this morning to welcome the President of the Latin American Society for Microsurgery, Professor Alexander Cardenas, from the Hospital General de Manuel G. Gonzalez in Mexico City. As I mentioned, Dr. Cardenas is currently the President of ALAM. He did his residency at the same hospital he is now, followed by a microsurgery clinical fellowship at Chang'an Memorial Hospital with the Professor Fu Chen Wei and Professor David Chuang, both of whom have honored us with talks during this series. He is currently the director of the Facial Palsy and Peripheral Nerve Clinic in the Division of Plastic and Reconstructive Surgery at his hospital in Mexico City. He is also professor of facial palsy and peripheral nerve Peripheral Nerve Fellowship Program at the National University of Mexico. And he also received the Puis Research Award from the Postgraduate University Program at the National University of Mexico in 2018. And as I mentioned, he's the president of ALAM, and we have the pleasure of actually working with Professor Cardenas on a combined symposium between ALAM and ASRM, which will happen in August. And we're very much looking forward to that. It's the first collaboration of its kind that we've had so far. And we'll have expert speakers from all over the world speaking on innovations in plastic surgery and microsurgery, as well as a video session and a keynote session by Scott Levin. So we're very much looking forward to that. Professor Cardenas, thank you so much for being with us, and thank you for working with us with ASRM and putting on the symposium. We really appreciate it.
Thank you so much for your kind invitation. So it's a great honor to be here with you.
Great, thank you so much. I just made you presenter, so you should be able to share your screen with us now.
Yes.
Perfect. And I'll ask everyone to keep their microphones.
Can you hear me? Can you see my screen?
Yes, we can see your screen.
Okay. So I will start. Good morning, everyone. It's a great honor to be considered as a Buncke Clinic virtual visiting professor, both due to the historical relevance of your institution, as well as the current impact of your practice has worldwide. My talk this morning will be focused on our surgical algorithm for developmental facial palsy. My name is Alexander Cardenas, and I work in a national referral center in Mexico City. I have no disclosures. The term developmental facial paralysis is used to describe facial asymmetry secondary to defects in embryological development. Meanwhile, congenital facial paralysis is used when the nerve is affected by exogenous factors, such as in utero infections, prolonged labor, or use of forceps. Developmental paralysis can present either isolated or as a part of a syndrome. The initial assessment must be performed as soon as possible. Thorough history and complete physical examination, presence or absence of other anomalies, unilateral or bilateral facial palsy. Topographic tests help us to locate the level of the injury and include Schirmer test to evaluate geniculate ganglion and proximal portion of the facial nerve, and tasting and acoustic reflex test to evaluate more distal injuries. It's important to perform neurophysiological studies to evaluate the nerve and the motor units damage. These tests must include electroneuronography, electromyography, nerve conduction time, blink reflex, and nerve excitability test. And finally, complementary studies like CT scan that allow us to review anomalies of the facial canal, including hypoplasia, aplasia, or bifurcation of the mastoid segment. MRI helps us to review anomalies of the facial nerve nucleus that may occur as a result of several syndromes. Our experience in facial reanimation has been developed largely in patients afflicted with Mobius syndrome or with the whole oculo-auriculovertebral spectrum, I will start talking about Mobius syndrome. Mobius syndrome is a rare disorder classically defined as a developmental paralysis of both facial and abducens nerves. Some theories have attempted to determine the etiology of the syndrome. The most accepted, it proposes that vascular obstruction of the basilar or vertebral arteries is the triggering cause. However, it's possible that some teratogens are involved too, especially misoprostol. Genetic analysis in these patients are usually normal. However, potential genetic loci has been localized in chromosomes 1, 3, 10, and 13. A total of 124 patients were evaluated. The most common subtype was classic Mobius with 88 patients, followed by 28 with incomplete and 8 patients with Mobius-like syndrome. 76 patients were submitted to surgical procedure. The rest did not, mostly due to young age and having been operated previously elsewhere. Our first goal is to describe the clinical and cytogenetic findings identified in patients with Mobius syndrome treated in our hospital. A female-to-male ratio of 1.7 to 1 was found, contrasting with other series that show ratios closer to 1 to 1. Gender distribution of the different subtypes of Mobius syndrome were very similar. The most commonly treated age group was that between 4 and 15 years old. Mean age was 8.61. In both groups, complete and incomplete Mobius, the most affected cranial nerves were the 3rd and 12th with 9 cases each, then followed by the 5th, 4th, and 9th cranial nerves respectively. Clinical affections were divided in main groups like craniofacial, musculoskeletal, neurological, and ophthalmological. Craniofacial malformations were mainly telecanthus, cleft palate, and microtia. Within the musculoskeletal malformations, we had clubfoot, syndactyly, and Poland syndrome. Neurological anomalies that were found were epilepsy and Dandy-Walker syndrome. Ophthalmological anomalies were convergent strabism and additional refractive problems like hypermetropia, astigmatism, and myopia, the most common findings. The most relevant anomalies in the phoniatrics area were dyslelias and dysarthrias. We found 11 cases associated with microgenia and 1 single case with TMJ ankylosis and microgenia. We documented 14 cases associated to maternal use of misoprostol and 1 abnormal curotype. This abnormal curotype was obtained in mother and child with Mobius, and it was a balanced translocation between chromosome 4 and 10 that has not been reported before. Now I would like to move to the second goal, which is to describe our surgical algorithm after reanimation of 91 phases with Mobius syndrome. Among the existing classifications, we have adopted the one proposed by Dr. Tarsis due to its clinical significance and easy to use. This classification divides the patients in 3 main groups. The first one is a classical Mobius with total bilateral facial and abducens nerve paralysis. The second group is incomplete Mobius, meaning some residual motor function persists on one side of the face, although this function could be subclinically affected. The third and least common group is Mobius-like. It applies to all patients with unilateral or bilateral facial paralysis with no affection of the abducens nerve, but with paralysis of another cranial nerve. The most commonly performed procedure was gracilis muscle transfer, neurotized to 3 different nerve sources, the masseter nerve, spinal accessory nerve, and contralateral facial nerve by cross-facial nerve graft to obtain double innervation, which we shall discuss afterwards. Temporalis muscle elongation using the orthodromic technique was performed sparingly, most of the time as a rescue procedure if gracilis flap transfer was unsuccessful. Few complications were reported. The most common was the need to reintervene the flap due to vascular problems. 6 flaps were lost, 1 presented a hematoma, and 4 patients required repositioning of the flap at the commissure several months later. The proposed algorithm is determined by the presence of unilateral or bilateral and the availability of donor nerves, determined through physical examination and electromyographies. Our preferred motor donor is the masseteric nerve due to its several advantages: proximity, consistent anatomy, and high axonal load. Should the masseteric nerve be paralyzed, the second choice is the spinal accessory nerve. A third option would be the hypoglossal nerve, as proposed by Dr. Tersis. However, we have not had the need to use this donor nerve. As mentioned previously, if a flap is lost and there is not an available gracilis muscle, we make an orthodromic procedure. In patients with classic Mobius, a typical two-stage gracilis muscle flap is performed, transferring muscle to one side of the face in the first stage and completing the treatment approximately 6 months afterwards with transfer of the second gracilis. The first cases that we performed were in this way, and it's important that you notice that we had some problems with symmetry between both sides and also bulkiness. After we had the visit from Dr. Zucker in our unit, we started to implement some refinements and improvements in cosmetic and functional aspects. Once our team gained some experience and confidence, then we moved forward to try bilateral simultaneous gracilis, following the publication from Dr. David Chuang. Our first case was a young adult. We spent a total of 6 hours in both sides with no complications. Then we performed the bilateral transfer of the gracilis muscles in a single episode in kids. In 2 patients, the flap was neurotized using the masseter nerve. In 2 patients whose masseter nerve was paralyzed, we used the spinal accessory nerve. In patients with unilateral paralysis, including incomplete and Mobius-like patients, our algorithm also depends on the available donor nerves. If the masseter nerve is available, we perform a double-innervated gracilis muscle, meaning that we perform a cross-facial nerve graft in the first stage, and in the second stage, a gracilis flap is transferred, and the obturator nerve is connected to the graft and the masseter nerve. Should the masseter nerve is not available, we use the spinal nerve, performing a single-stage gracilis transfer. Dual innervation is a new concept that implies the attachment of 2 nerves to the transferred gracilis muscle. It can be done in 1 or 2 stages depending on the patient's needs or surgeon preference. In patients with incomplete Mobius, it's possible to get axons from the contralateral side. However, healthy side is possible to have subclinical affection, and the input that we can get is probably lesser than in a healthy patient. That's why we prefer a double-innervated gracilis flap in order to add axons from masseter nerve during the second stage. Here you can see several configurations for dual innervation of the gracilis with cross-face nerve graft and masseter nerve, and in an end-to-side or end-to-end fashion. We started as an option A, and now we are moving to the option D. The free functional muscle transfer is carried out once reinnervation of the cross-facial nerve graft has been confirmed by Tinel-Sein and neuroconduction studies 3 to 4 months later. The landmarks in the face are the nasolabial fold, the zygomatic arcs, and the malar bone. 2 surgical teams work simultaneously. The head team begins the operation by making a preauricular incision of the paralyzed side. The cheek flap is dissected in a subcutaneous plane above the parotid fascia. A layer of fat should be kept on the retidectomy flap to avoid dermal adhesions to the muscle transfer. The dissection is carried anteriorly until the anterior border of the masseter muscle is found. The zygoma corresponds to the superior limit of the dissection, while the mandibular border is the lower limit. At the anterior border of the masseter, the facial vein is identified. The buccal fat pad is extracted carefully using blunt dissection in the attempt to facilitate the facial vein dissection, but also helps to reduce cheek volume while avoiding the need to debulk the gracilis muscle. And directly anterior to the vein, we found the facial artery that is dissected towards the oral commissure, and it's divided and pulled towards the incision. If the facial vessels are absent or small, the superficial temporalis artery and vein are dissected. The surgical plane required to dissect the facial artery near the oral commissure is where the anchoring stitches should be placed. Once identified auricular isoris, the modiolus, and the zygomatic muscles, it's important to apply ovicrial stage sutures to each landmark, using figure of 8 stitches as anchoring technique. Once the sutures have been positioned, the nasolabial fold should be recreated when traction is applied. Once we complete this step, then we proceed to perform the muscle measurements that must be done with a gentle traction of the sutures towards the periauricular incision. It's possible to make a template to be sure the correct positioning of the muscle and the pedicle once we insert in it. The masseteric nerve is identified by performing blunt dissection at the mandibular notch, rejecting the parotid gland and the masseter muscle fibers. Once the nerve has been isolated, it's transected and is most distal portion and directed outwards. The next step is to identify and dissect the Buncke cross-facial nerve graft and the masseteric nerve. The cross-facial nerve graft should be harvested from the location where it was bunked. While the first team works on the face, the second surgical team harvests the gracilis muscle. A short 7 cm skin incision over the posterior border of the adductor longus muscle is made, approximately 3 cm below the inguinal crease. Circumferential dissection of the muscle begins by surrounding its proximal and distal edges using a Penrose drain to use for traction. The adductor longus muscle is rejected and the gracilis vascular pedicle is identified, dissecting it carefully until its origin at the femoral vessels. The obturator nerve is identified and stimulated to verify adequate contraction of the muscle, and it's followed until its emergence. Once the neurovascular pedicle has been adequately identified and isolated, the muscle is trimmed in a trapezoid shape based on the measurements made by the face team, adding an extra 1 cm to its length to allow suturing at the edges. The muscle is transected with an intestinal stapler. Once dissection on the face has been complete, the vascular pedicle is divided using surgical clips and the nerve is transected. The muscle is transferred to the face, its proximal tendon is lowered and anchored to the nasolabial fold using bilateral sutures applied previously. Anchoring sutures should be performed using a row matrix sutures, as described by Dr. Zucker. This avoids muscle fiber tearing and secures the muscle in its plane position, limiting posterior migration of the nasolabial fold. An end-to-side coaptation from the masseteric nerve to the obturator nerve about 1 cm proximal to the gracilis muscle hilum. An end-to-side neurographies require performing a perineural window on the side of the motor nerves to allow the axonal sprouting, as described viterbo. We usually perform the arterial anastomosis first and then perform the venous anastomosis using the comitant vein that ingurgitates the most. After the neurovascular repairs, the distal end of the muscle is anchored to the preauricular fascia with matrix sutures. Any redundant muscle tissue is removed until adequate tension is achieved, which is seen as a sleep pull of the commissure. And finally, an end-to-end anastomosis is performed between the distal end of the cross-facial nerve graft and the obturator nerve. The double-innervated gracilis flap combines the stimulus of the contralateral facial and masseter nerves and takes advantage of the strengths of both neural sources, symmetry and spontaneity from the first one, and quick reinnervation and contraction force from the second one. Here we can see a patient who received a double-innervated gracilis flap. With this technique, the patient can get the best from each motor donor, a spontaneous smile and a strong muscle contraction, and the chance to activate the muscle with either donor nerve. This concept would be used even in young adults with good results. Some cases have muscle activation in the lower third, coming out from the platysma innervated not by the facial nerve, but the cervical plexus. In those cases, we have performed a mini gracilis to improve functional and aesthetic result, inserting functional flap in the correct vector of motion, and doing a myectomy of the pressus of the inferior lid at the same time. And the results are maintained by the facial growth. Finally, we present an example of facial reanimation using the spinal nerve. Although this is not a Mobius syndrome case, we bring out as a good example of dissociation from the trigger of donor nerve that is not always possible in kids, at least in our experience. The procedure is performed in a single stage with good results. We are currently exploring the possibility to perform a double-innervated gracilis with the spinal and the contralateral facial nerve for this kind of patients. Now I will move to the second developmental disorder, which is the oculoauriculovertebral spectrum, that primarily involving structures derived from the first and second pharyngeal arch during embryogenesis. Oculoauriculovertebral spectrum includes conditions like golden hair syndrome, hemifacial microsomia, lateral facial dysplasia, oculoauricular vertebral dysplasia, facio-auricular vertebral spectrum or sequence, and first and second brachial arch syndrome are also used. But it is now accepted that those conditions are part of the same clinical spectrum and varies from mild to severe phenotype. Associated anomalies include eyes, nerves, brain, heart, kidneys, and other organs and systems. The facial nerve from this condition is affected between 10 and 45% of the cases. The phenotype is clinically heterogeneous and is typically characterized by abnormal development of the ear, mandible anomalies, and defects of the vertebral column. Omen's classification evaluates the function of the facial nerve with anatomical and clinical parameters. Omen's stands for orbital asymmetry, mandibular hypoplasia, ear deformity, nerve dysfunction, and soft tissue deficiency. But regarding facial palsy, this scale evaluates subjectively and statically the function of facial nerve. E-face is a new scale to measure the function of the facial nerve and the symmetry of the face at rest and in motion. It includes 16 sections that evaluate symmetry at rest, dynamic symmetry, and synkinesis. However, this scale had not been applied to this malformation. We described its useful for the sequence in this publication 2 years ago. We evaluated different areas of the face with this scale. For static scores, the face were divided in thirds. In the upper third, we evaluate the position of the brow and the palpebral fissure. And in the middle third, we evaluate the nasolabial fold and the commissure position. Regarding dynamic score, the upper third was evaluated by brow elevation and eye closure, the middle third by nasolabial fold orientation and depth, and excursion of the oral commissure, and the lower third by activation of lower lid, producing the E sound. And finally, the scale incorporates the synkinesis parameters in different areas of the face. From a total of 97 patients with diagnosis of oculoauriculovertebral spectrum in our unit in the last 5 years, we had 32 cases with facial palsy, 12 men and 20 women. There was no statistical significance between laterality. The main affections related with facial palsy, according with Omen's classification, were ear deformities, followed by mandible and soft tissue hypoplasia. Focusing specifically on facial nerve function, most patients were considered as N3. However, no further information for analysis was obtained. In contrast, E-phase can provide further information for each area and region. Talking about the static score, it's evident that the position of the brow and nasolabial fold were more compromised in these scores. Dynamic scores were more compromised in the upper and middle third, particularly in periocular movements and oral commissure movements, as you can see in the graph. Regarding the neurophysiological studies, the distribution by branches affected is shown as follows. All branches were affected in 23 cases. 3 cases were evaluated as frontotemporal affection, 2 cases with zygomatic buccal affection exclusively, and 3 cases with frontal branch affection. In 1 case, the marginal branch was affected. Regarding the potential donors to facial nerve, they were evaluated with neurophysiological studies, and we detected trigeminal nerve dysfunction in 12 cases and hypoglossal nerve dysfunction in 3 cases. We performed 23 procedures in 19 patients. No statistical differences between gender and laterality were found. The average age was 12 years. Most procedures were applied to middle third, followed by upper third, particularly to improve the periocular function. The most common facial reanimation procedure was the cross-facial nerve graft between buccal branches and a masseter to facial nerve transfer to a second buccal branch. The goal of both procedures were to improve function of the middle third of the face. Improvement is evident on the nasolabial fold, which has deepened, and on the position of the oral commissure. In this case, we add a second cross-facial nerve graft to improve palpebral closure. Some patients were operated very early in life, around 2 years of age, achieving better symmetry and natural facial movements. In adults with partial nerve activity, static procedures can complement cross-facial nerve graft. Despite great advances in facial reanimation, there are still several problems waiting to be solved, such as abnormal facial movement due to hemifacial spasm or synkinesis, or the inability to replace small muscle actions in the face. Lastly, I would like to talk about some of our recent research and innovations. Our research is related with the changes in the masticatory force and electrical activity after using the masseter nerve for facial reanimation. We know that masticatory function and strength depends on the contraction of the masseter muscle. However, morbidity and impact of masseter nerve transfer is still debated in normal patients and in hemifacial microsomia patients. Most authors agree that masseter nerve transfer has minimal morbidity. However, evidence is limited. Most of it stems from clinical series, such as those by Klebuk and Ontanilla, who report that their patients seldomly complain from alterations in the temporomandibular joint. A pair of reports aim to find morphological changes in the muscle after denervation. However, their study did not evaluate any functional outcomes. As of today, there is no published data aimed at determining the functional impact that the use of masseter nerve in facial reanimation surgery has. So our objective was determine impact of masseter nerve use in electrical activity of masseter muscle and the masticatory strength. Our sample include patients with unilateral facial paralysis in whom dynamic facial reconstruction was performed using the masseter as donor nerve. It's a prospective study. We include general variables. Specific variables were the result of surface EMG and masticatory strength. Both sides were evaluated preoperatively and 3 months after the procedure. Electrical activity of the masseter was evaluated with surface EMG. Asking the patient to bite as strongly as possible for 5 seconds, first at maximal intercuspation and afterwards with introduction of a tongue depressor to avoid posterior contact. Masticatory strength was measured with a computerized occlusal analyzer developed by this study. Each patient was asked to bite at maximum strength for 5 seconds, and with the use of the sensor and specialized software, maps were indicating the intensity and location of the bite. Afterwards, global and individual values for each side of the jaw were reported. Clinical variables were evaluated with descriptive statistics. Comparative analysis was performed with the Wilcoxon sign rank test due to the non-parametric distribution of the sample. 15 patients were included, 9 females and 6 males. Mean age was 24 years and most cases were right-sided. Etiology of the paralysis was developmental in most cases, followed by Bell's palsy and only one case of postoperative paralysis. The masseter was used as donor in 7 cases of masseter buccal transfers and to innervate a free functional muscle transfer in 8 cases. Electrical activity showed a significant decrease after surgery at maximal intercuspation on the intervened side of the face. The decrease in electrical activity was also present and significant at the occlusal position with no posterior teeth contact. We decided to compare the differences between the operated and non-operated sides of the face and also found a significant decrease in electrical activity on the side that was operated upon. EMG results contrasted with those of masticatory strength. Surprisingly, we did not find significant differences after surgery, not even when compared both sides of the face in the immediate postoperative period. Our study shows that after using the masseter as donor nerve in facial reanimation procedures, the electrical activity of the masseter muscle is reduced, but masticatory strength was unchanged. We have developed 2 theories in order to explain this. The first is that the masseter muscle atrophies after denervation, but the remaining muscles of the masticatory apparatus develop compensatory hypertrophy. And the second could be that the denervation of the muscle is only partial. Anatomical studies have shown that almost 80% of the population has 2 or more branches of the masseter nerve. Therefore, it could be possible that one of those is preserved. Main strengths from our study are its prospective nature and the fact that there is the first time that a functional impact has been studied for masseter nerve transfer. Main limitations is the sample size, and in the future we would like to study the impact of the transfer may have in skeletal development in children. So in conclusion, the use of the masseter nerve as a donor in dynamic facial paralysis reconstruction reduces electrical activity, but does not alter masticatory strength. Therefore, we can conclude that masseter is a safe donor nerve with very low postoperative functional impact. So the previous study was the basis to develop a new procedure to restore the masticatory function in one patient with hemifacial microsomia. And we plan to replace the masseter with a functional muscle transfer in 2 stages. In the first stage, we use a cross-facial nerve graft from the contralateral masseter nerve with an end-to side neurography. And in a second stage, we transfer the gracilis muscle using the facial vessels as receptor vessels. This way, improving significantly the facial contour. But surprisingly, finding an improved bone density in the previous distracted mandibular ramus. We can observe an adequate muscle contraction of the transfer muscle during biting. Recently, a Brazilian group published the use of neurotized muscle grafts to restore blinking. Although clinical results were not constant, they were able to prove that muscle grafts activity can be detected using EMG, opening the possibility for new research. Our team has published and worked on developing the omohyoid muscle as a viable muscle flap or graft for facial reanimation. We have explored its application as a zygomatic muscle replacement in patients with Mobius syndrome. Although we still have small patient series, and the post-op results are subtle, we consider the operation can be justified in order to improve a patient's self-image. It's important to move towards international homologation of diagnostic and treatment criteria in order to provide uniformly adequate outcomes to our patients. We have the honor to participate in this consensus that was performed together with 20 experts from around the world, and it was the first attempt to get the most important aspects to evaluate in each case. So in conclusion, Mobius syndrome is a rare condition. This is one of the biggest cohorts in the world. Preoperatively planning, including donor nerve evaluation and neurophysiological studies, are helpful to get better results. Our study describes our algorithm and strategies in this kind of patients. eFace is a user-friendly tool with more accurate and complete information than OMENS. EMG provides important information for decision-making, including subclinically compromised donor nerves and the state of recipient nerves, candidates for reinnervation versus replacement. Thank you for your attention.
Wow, Alex, thank you so much. This is one of the best facial reanimation talks I've definitely seen, and definitely one of the best talks that we've had on this series. I'm going to open it up to questions from the audience as well. If there are any questions, I'll go ahead and get things started. One thing that I particularly liked about your presentation is how many videos you have. I feel like, you know, watching your talk, I can see exactly step by step what you're doing, and the videos are very high quality. So that was really nice to see. Thank you so much. The other thing is, sorry, go ahead.
Yes, I would like to introduce my past fellow, Jose Telich, who helped me with to prepare the lecture, and he has collaborated and has been a co-author of this work. So I asked him to help me with technical and language issues, since my English is not very fluently.
Excellent. Well, Jose, thank you so much for all your help, and Alex, your English is perfect. It's a lot better than many of us here in the U.S. So I think you're being quite humble, but no, thank you for that fantastic talk. It's especially interesting with your research because traditionally, the nerve to masseter, you know, in the traditional teaching they've always said, oh, the nerve to masseter is not good because of these other reasons. But what you've shown is that you can get very good results with the nerve to masseter if it's done right. And your research has shown that, and your clinical cases have definitely shown that as well. I have a question about the development of a center like yours. These are obviously very rare cases. There are not that many Mobius cases. So tell us about your journey as far as how you were able to develop a center with so much volume, and how you've been able to basically have about 80% of your practice be dedicated to facial palsy, because it's a very unique practice.
No sé si quieres comentar que bueno, pues fue una práctica que empezó en el 2008, que ha sido pues obviamente un crecimiento constante en todo este tiempo.
Well, nice meeting you, everyone. The clinic first started back in 2008, and Dr. Cardenas was coming back from his training in Taiwan, and you were at the National Institute of Neurology, and it started, I know, little by little. The Gea Gonzalez Hospital is a reference center for craniofacial surgery, so they already had some cases of Mobius syndrome and a lot of cases of patients with hemifacial microsomia. So that was kind of like the start of everything, and little by little they started going. Dr. Cardenas was also part of the Mobius Syndrome Foundation in Mexico. Has been very important for the development of our center, and they tend to refer all patients that are part of this foundation to the hospital to get all their treatment.
I see. Great. Yeah, it's very unique to be able to have a practice like Dr. Cardenas's, because you know, most people just simply don't have the referral source. And I think it's the key is to like just like he's done, to become the place that everyone comes to, not just from Mexico, but I'm sure from other countries in Central America, probably in the US as well, and probably in South America as well. So congratulations on having been able to set up that system. I just got a text from our dear friend from Ganga Hospital, Hari Venkatramani, saying that they also love using the nerve to masseter. So they are in the same boat, if you will. And the question was, is there a role for Botox to the normal side to potentially speed up recovery in these cases when it's a unilateral case?
Esperamos la recuperación del lado, o sea, reconstruido para poder ofrecer la toxina botulínica, pero normalmente en los niños casi no se usa.
Oh. Well, first, Dr. Cardenas prefers to do the surgical procedure and the reconstruction and wait until the patient has completed rehabilitation and all the process before applying Botox to the contralateral side. And in children, we haven't really used this only after they've reached like maturity.
Mm-hmm. Got it. Great. There was also a question in the comment section about the use of cross-facial nerve graft and the nerve to masseter simultaneously. When you do that, are you using the nerve to masseter as a babysitter to then disconnect and reconnect with the cross-facial nerve graft, or what's the rationale behind using both?
Yes. Sí, o sea, la idea es que el hacer la doble innervación, o sea, que dice que si lo desconectamos después el hipoglóbulo, etcétera. Entonces.
No, actually the dual innervation procedure is, well, at our center it's done in two phases. So first we do the cross-face nerve graft, and in a second stage the gracilis muscle flap is innervated with both the masseter and the cross-face. So it's in two stages, unlike Dr. Bigleli's technique, who does it in a single stage, but we don't dismantle the neurography at any point.
Got it. Okay, great. And the rationale behind that, in case I missed that, do you get increased strength because you're doing a primary coaptation with the masseter? Is that the rationale behind using both the dual innervation?
La idea es que sumamos acciones porque en los nuevios normalmente hay disminución o afección subclínica.
Yes, well, we try to get the best from both sources. So especially in patients with incomplete Mobius who have unilateral paralysis, but the healthy side is a bit weak as well. So we complement the axons from the crossface. The crossface gives us spontaneity and some symmetry, and we complement that with a masseter to get more strength and some more axons to get a good contraction of the muscle.
That makes sense. Thank you for the clarification there. Let's see here. So there's a question from Dr. Dario Fernandez from Colombia. He's asking about the protocols for postoperative rehabilitation and the use of electrical stimulation if you use that postoperatively.
Sí lo usamos 6 semanas después, es la primera fase. La primera fase es desinflamatoria, la segunda fase ya es con estímulo eléctrico hasta que logramos contracción, la tercera fase es reeducación muscular, básicamente.
Okay, so yes, we have a rehabilitation team working with us. First, we do like of anti-inflammatory therapy, control edema. After 6 weeks, after the 6th week, our team starts doing electrical stimulation until we can see muscle contraction, and then we start with re-education for contraction and smiling.
Oh, got it. Perfect. Great. Thank you so much. Looks like we don't have any other questions in the chat area. So Dr. Cardenas, thank you so much again for being with us. It's been an honor, pleasure to have you. Jose, thank you so much for your help, not only with the research, but also with the talk today. I want to mention a couple of things from a housekeeping standpoint. I just pasted a survey in the comments section, and I ask all of you kindly to fill it out if you have time. It just takes a few minutes. We're doing a study on online webinars in plastic surgery with JP Hong, Tommy Chang, and Jamba Masia, and Hina Rockhorst from the Netherlands. And we'd love to get your input on that. The other thing that I want to mention as well is that, as I mentioned yesterday during Dr. Mendieta's talk, Professor Cardenas, in his leadership role as president of ALAM, has been working with us at ASRM along with Mauricio Mendieta in putting on a very exciting program, Innovations and Expertise, which will happen August 22nd of this year at 8 a.m. Pacific time. So it's a great collaboration with some fantastic speakers. So keep that in mind, and you'll see a lot more information on it in the coming weeks and over the next month. Alex, thanks so much again for being with us. It's an honor to see you virtually. I hope to be able to see you in person soon.
Of course. Thank you so much for your kind invitation. It was a great honor to be with you.
Great. Thank you very much. Appreciate it. You have a great day.
Thank you.
Thank you. You too.
Thanks. Bye.